there is definitely a teachable moment. So this concept of in-hospital initiation of the bundle of cardiovascular protective medications, here's from an editorial we wrote in Circulation 2001, and in fact the guidelines did get updated. So all the national guidelines now embrace this concept of in-hospital initiation of lipid-lowering therapy along with other cardiovascular protective medications. So it has become the standard of care with regards to that. So there is a science to implementation that we can take advantage of some of these key lessons. And critically important, how can we get this to outpatient? How can we get this to primary prevention? And what are the key lessons there? Well, certainly to have this sustainable kind of program and impact takes a team approach. So get with the guidelines, participate in the hospital, all these collaborators, physicians, nurses, pharmacists, administrators, directors of quality improvement, rehab team, all working together, looking at the data, where are the barriers, designing protocols, and going forth, customizing them for their local environment, implementing them, and looking at the data. So champions leading this and supporting these cycles of quality improvement. But key is having current and accurate data, having set goals, implementing them, and then further refining, analyzing those treatment rates, and further adjusting. Now there are absolutely challenges to implementation of these kind of approaches. Here are a small sample of the billions of reasons we've heard why this won't work in our system, or the barriers, or it's cookbook medicine, or it costs too much, or not enough time, or all of these things, but they can, in fact, be overcome. We do also see variable adoption. So here's some data looking at whether the clinical decision supports were actually used or not. And there's a lot of variation, but when they're used, there's much higher adherence rates and much better clinical outcomes that are demonstrated. So when you look back in these programs and say, well, some hospitals did incredibly great and others signed up but didn't really see much improvement, what distinguishes them? This Harlan Krumholtz and Elizabeth Bradley's work looking through National Registry of MI. And this is what they found among the hospitals that had succeeded over time, where they utilized the data, so having access and sharing accurate and current data on treatment and outcomes. Physician champions, support among clinicians, having stated goals, key of getting administrative buy-in and support, use of the clinical decision support tools, and importantly, use of the data to provide feedback to the clinicians that we're actually caring for the patients rather than just locked away or just shared among leadership and the administration, but not among the day-to-day clinicians. So, outpatient, could this same type of approach work? Wasn't a whole lot of data. Here's from a study that we've done in heart failure, looking at 167 outpatient cardiology practices where we took the same model for heart failure, 7 evidence-based therapies, collected data, and then fed it back to clinicians where they could track over time and drill down to individual physician and patients and have order sets and protocols and those type of things. But in the outpatient setting where we thought it'd be a whole lot more difficult. 6 of the 7 key evidence-based therapies for heart failure were able to be in a clinically meaningful way improved. And but is it anything improves? No. Actually, interesting, anticoagulation for AFib we were not able to budget off. So, it doesn't solve everything, but at least for 6 of these 7 measures, and some of these things, documented, and some are really difficult. Identifying patients for cardiac resynchronization, getting them referred to electrophysiologists, actually implanted, consistent with Class 1 recommendation, the guidelines, these very large impact. We were also able to show further data. You improve the use in outpatient setting. In the real world, it translates to improved clinical outcome. Applying the guidelines in real-world patients improves outcome. There is the American Heart Association Guideline Advantage program that's trying to scale this up for primary prevention and secondary prevention in outpatient primary care and cardiology and diabetes practices that collect data, use the feedback in this sort of loop. It's still early in the experience. The ACC has a Pinnacle registry that is also going. So there is early work going on of trying to scale this up across practice, and of course your great work trying to scale it up across communities and health plans. But this concept of feeding back data and this approach that we've shown that worked in CHAMP, worked in Get With Guidelines, worked in Improve HF can work, but of course needs to be scaled to a much larger degree to get to all of the primary and secondary prevention individuals. Okay, so now let's talk and shift a little bit about, is this actually worthwhile and what are the costs? So certainly in secondary prevention, these therapies are all cost effective and accepted, but as we move to primary prevention, people do start debating more about the cost. And I'd say, but not treating has tremendous cost, and the average 5-year cost when somebody has an MI or needs revascularization is also fairly substantial. And although sudden death may look cost effective, it's certainly not what we want to happen to our patients. So as we talk about these therapies, even at full branded price, they were all highly cost effective and far better than performing revascularization or other things that we were routinely applying. We clearly had, and to this argument about, do we have the evidence? Here's some further data trying to look at this between hospitals, conformity with the guidelines versus those not conforming, lagging and leading hospitals. You could say, let the hospitals do whatever they want. Some use a lot of these therapies, others use a lot. Does it really matter? Do we have national data that says following the guidelines translates to better outcomes in this setting? And there were huge differences in outcomes. And so improved hospital adherence over 10% greater conformity with the guidelines translated to 10% lower risk of in-hospital death in the case of ACS. And we also have data looking at patients subsequently. So here's the bundle of therapies in real-world patients when added after a coronary event. And looking at 6 months, and you can see clearly cumulative benefit. And oh, look at this. Seems to be this 70–80% risk reduction expected on the clinical trials, seen in CHAMP, also seen in this broad experience. So we have more and more data stacking up to demonstrate the real-world clinical effectiveness, the cumulative benefits, the incremental benefits, that this is indeed worthwhile. Well, so you've shown me some national data where uptake started to occur. You got all these hospitals and get with the guidelines and doing this. Has it actually translated to better outcomes? Are we preventing patients from now having events and having recurrent events? So here's data that we have, which is for fee-for-service Medicare. So in the time period where we rolled out these programs pretty intensely, so 2002, 2007, I'm looking at hospitalizations for AMI, unstable angina, CAD, and heart failure. And you can see fairly substantial reductions now being achieved in a way we were not seeing with just the NCP guidelines before we had these implementation systems here. These risk reductions on the order of 12 to 59%. So extrapolated to all of the Medicare population, this would be 1.4 million less cardiovascular hospitalizations in 2007 versus 2002. And saving $14 billion in direct costs to Medicare each year just with this greater implementation translating to better clinical outcomes. But there's a lot more that we could have done with even better implementation and getting to primary prevention in a much more scalable way. So here's where we've been, right? Acute event, post-event, those with known disease. And why? Because that's been the lower hanging fruit. There were only 4,500 hospitals we had to get into to get systems in place. But as we start to move outpatient, now we're talking 175,000 different outpatient practices. And the challenging population here of underdiagnosed or undiagnosed and untreated, how are we going to get to those individuals at risk with very effective therapy where they can apply and where we have scalable, sustainable systems that will utilize our evidence-based primary prevention therapies to improve outcomes? Was it worthwhile? Should we be doing it? Well, the expectancy in life that occurs once you manifest clinically atherosclerosis is profound. So trying to prevent in the first place is absolutely critical. Now, this may be a little sensitive, but I'm just going to go here. Our current NCP guidelines have never been evidence-based, have never been patient-centered. They've been all about healthcare rational. So they've been framed as lower risk patients, their risk-benefit ratio for the therapies isn't as great, their side effects of the meds don't treat them. High-risk patients certainly treat them intermittently, intermediate patients start with diet and exercise and maybe you get to meds. And, you know, the rationale here was, so we're looking at, you know, the lowest group, 1% per year or less, intermediate risk group, 1 to 2% per year, and the high risk group, those with documented disease or diabetes, 2%, or with the lowering therapy, which are a minute. Well, you know, if you look at their absolute risks for events, it's clearly higher in the higher risk group, but the relative risk reduction in the clinical trials with lipid-lowering therapy have been absolutely identical. And intermediate dose statins, you get about a 32% risk reduction. So here's the NNT for benefit. It's clearly much lower for the higher risk patients, gets to 100 here. But here's the NNT for harm over 5 years. So, you know, it's still multiple fold favoring benefit over harm. But here's what it was all about, the cost per event avoided. You know, down here at 25,000 of fully branded costly statins before they were generic. Here, 100,000 too expensive, we don't want to do it. So this was a basis for the guidelines. But was this really rational? And wouldn't, if you just cut 40 milligrams of atorvastatin into a quarter, you get the same cost per event avoided? Was this really a rationale for withholding therapy? But in fact, it was and is. So now that they've gone generic, it's freed it up, but you know, all of this moves down. But we still have guidelines that have this kind of framework. So I just throw that out there to think about. Now, what's our cost? Our costs have come down dramatically. All these therapies have gone generic, and we can, for an entire year, use the 4 meds in combination. It's $125 at, you know, buying it online or going to your local Walmart, and even lower if you're directly getting the medication. So cost really starts to come out of the equation, and we can even do potent LDL reduction with 40 of the atorvastatin, get 50–60% reduction LDL, where it's going to be down to these $40 a year. So, you know, your 5-year cost becomes, you know, $500–600. Your 10-year cost at most is $1,000. And in fact, you look at the reduction in revascularization. You prevent 1 cabbage, you've just traded, you know, 5 years of treatment for 50 patients. In fact, you lose money if you're not applying these therapies to secondary prevention. Okay, so now cost is out of the equation. Let's go aggressively to who's at, you know, at least intermediate or moderate risk, 1 to 2% per year, where take their risk from 10% or 20% over 10 years. Let's cut that in half. And in fact, you start to see for men and women, just age alone starts to give us a lot of information. If we want to say we want to go after MI, stroke, death, or revascularization, you know, for men without diabetes, the age cuts right there at 51, and for women at 58, they've got diabetes, it's right down here at 32 and 38. So here's the group, let's go after them. That alone is sufficient information to cut their risk in half with, say, aspirin and a statin together. Now, is that going to help us get more patients? Well, let's look at our current, you know, cutoffs and say, all right, well, if we just target people with LDLs above 100, you know, how many events are we going to miss? So here's data looking, national representative data, 36,000 patients having an acute event. What number occurred in patients with LDLs below 100? Half. So we're missing out on half the events that this is all we're targeting. We need to move much more aggressively. Okay, well, is there something magical about 100? No. I mean, the data is absolutely continuous here. So if you start off at an LDL of 200, you lower it to 100, you've cut their risk by half. If they start off at 100 and you lower it to 50, you've cut their risk in half. Now, what is their absolute risk? That has a lot more to do than what is their LDL. So understanding the absolute risk and then maximizing risk reduction. Okay, do we have evidence that actually shows it? Here is as a function. This is pulling together all of the statin data that exists. 27 trials, 175,000 patient year experience in the analysis. And you can see no matter what your baseline risk was, including the absolute lowest risk group, you got major risk reduction, no attenuation of benefit. If anything, it goes in reverse because you're on low odds ratio. So this is a continuous relationship. We can get huge risk reduction. Give me direct evidence. I want to see if the benefits outweigh the risk. Well, here's the Jupiter study. So what was, 17,000 healthy men and women who got into trial because their LDLs were good. They were below 130 on average. They were 100. They had no atherosclerosis, no diabetes. Were randomized to 20 of statin versus placebo. Trial was supposed to go 5 years. They stopped after only 2.5 years. So let's look at the group that got treated in an LDL less than 50. And what we see in this group compared to placebo, 65% reduction in major CV events. MI, stroke, CV death, 74% reduction, 3/4 of the events gone. All-cause mortality reduced by 46%. Live longer? Wait, primary prevention? I thought statins don't help you live longer. They absolutely do. Here's the data. 59% reduction, major CV death, VTE death, all highly statistically significant. What about the adverse effects? Well, identical among those on placebo and on statin. The withdrawal rates for myalgia were absolutely identical. However, there was a slight increased risk of new onset diabetes. 254 patients treated over a 3-year period. You had 1 excess of diabetes, but 15 less vascular events. So there is that one factor that does come into play. So for primary prevention, it's this log linear relationship. So statins have been shown to reduce cardiovascular risk in all of the following circumstances. Older age, younger age, men and women, diabetes, no diabetes, metabolic syndrome, no metabolic syndrome, hypertension, no hypertension, smokers, non-smokers, family history or not, regardless of your LDL, your HDL, your triglycerides, your non-HDL cholesterol, regardless of the buoyancy of your LDL, what your CRP is, what your homocysteine, what your LP little a is. So I view this and say, okay, this is ultimate in highly personalized medicine. You're a person, you get treated with the statin, you bet. Because that's what the trials show. Now, somebody at so low risk, they don't need to be treated, but what we need to then define who's at risk, get them on treatment, and that treatment, the benefits outweigh the risk. So, you could make the case, and this is not in any national guidelines, but this is just saying, let's be aggressive here. If we want to knock out cardiovascular events in a community, then we need to be aggressive here. And if we apply this aggressively to those at risk, and you can pick up different cutoffs, whatever you like, to define that population, but we could greatly reduce the number of events occurring going beyond current guidelines, but solidly within our evidence, and define the risk benefit and the financial benefits that would occur with aggressive primary prevention. So we had estimated early in launching with the guidelines, CAD and CHAMP, if we could get these kind of good treatment rates, this is for secondary prevention, these are the number of events we could prevent each year. And it actually worked out that way. These are the number of events that have been reduced over this period where this has been implemented. But these numbers pale in comparison if we were more aggressive on primary prevention. We could knock out about 80% of these cardiovascular deaths, the number 850,000 a year. The 1.4 million myocardial infarctions, that could be down to 200,000. A lot of my interventional cardiology colleagues will be looking for other things to do. But we could do this with more aggressive prevention. So my view here is national cardiovascular care quality improvement. The time's now for every patient we personally see that they're on evidence-based treatments. Colleagues we're working with are treating, and the hospitals, the outpatient practices, the health systems, and the communities that we work in have treatment systems in place to prevent and treat atherosclerosis, apply our evidence-based therapies, and we can markedly improve outcome. So conclusions, comprehensive application of primary and secondary prevention therapies, highly effective in reducing the risk of cardiovascular events. Despite clinical trial evidence, national guidelines, we still have a large number of eligible patients not receiving one or more of these recommended therapies, and thus having events that could have been avoided if there was better implementation in this. Every effort should be made to bridge this cardiovascular risk reduction, prevention, and treatment gap that we currently have. So my view of atherosclerosis is like the tiger. When it strikes with deadly force. Once our patient has atherosclerosis or sufficient risk, we need to build a cage around the tiger. In short, get with the guidelines or get eaten. So, thanks for So I'll be happy to answer questions, and then we can go to the questions I have for the group.
Now we have about 15 minutes before we're going to go to breakout groups. Was that fantastic, folks?
First, I'm sorry, having come to UCLA in 1994, I watched this whole thing unfold under Gregg's guidance, and it was truly amazing. But at UCLA, we have a new verb before we discharge patients, which is, did the patient get champed yet? So literally, the house staff has used that verb for the last 10 years when I've been on service. So Gregg has definitely gotten us into the modern our place. I had two questions for you. One was about one of the final studies you showed, looking at LDL levels and event rates. And I wondered in your lower groups, how many of those patients were already on therapy? Do we know that?
So the patients that came in with MIs that had LDLs that were below 100.
Yeah, you had like those 3 bins of LDLs, and
yes.
you showed the event rates.
Yes.
Yeah.
So it was about, when you looked, it was about 28% that were on therapy. Now, how many should have been on therapy? If you look back by their history, that they had had prior events, and otherwise it was close to 2/3. So it does factor in a lot of these patients, still going back to that original slide of the big 4, those patients, they either had diabetes or had smoking or past or cholesterol or hypertension issues at some point. So it tells us that it doesn't mean all the risk equations are out, but so much is driven by other risk factors other than LDL. But if you look and said, if we had optimally managed these patients and everybody had LDLs down at, how many people came in with LDLs of below 50? It was, incredibly small. Now, granted, it's from a small end, probably out in the community at these low rates. But in our trials, those who have been treated down to 40 or 50 in LDL, who have had large percent reductions where the risk reduction corresponds with, there are these very small event rates over the 2 to 5 year follow-up in the trial. But there are a lot of people who are coming in where they have been on treatment but are not been treated to goal. There are some that come in where they have been treated to goal, but they started off with an LDL that was only 100 and somebody lowered it to 90 and said, oh good, I'm below 100, things are great. But you're leaving a lot of benefit on the table if you just look at goal attainment rather than the percent LDL reduction corresponding to the percent risk reduction. That would take you, somebody who's LDL 69 on no therapy, you'd still say there's benefit there if I lower more aggressively. Somebody who's at 101, my goal isn't to lower them to 99 or even to 70. I want to lower that patient through a greater percent LDL reduction, higher dose, more potent statin that gives me a larger benefit.
Right, so I would say that there's solid evidence in the secondary prevention world to support that statement. I think in the primary prevention world, there's an absolute risk reduction, but there's a relative risk reduction, but the absolute risk reduction may be quite small. And the primary prevention person who comes in off the street with an LDL of 75 untreated.
So you're absolutely right, and that's where their other risk factors come into play.
Right.
So if they're 20 years old and no other cardiovascular risk, absolutely correct. Well, their relative risk reduction is exactly the same.
Right.
You put them on 20 rosuvastatin, it's 50%. But their absolute reduction over 20 years to go from 1% to 0.5%,
right.
That is not worthwhile. But if you now make it a 70 or 80-year-old, their risk, just by that alone, same LDL, no other risk factors, they're many-fold higher in their absolute risk. So I agree with you that it absolutely becomes NNTs, number needed to treat, or absolute risk reduction. But the difference is not between primary or secondary prevention. It's really what is the underlying risk of that patient, and that's where Framingham risk score or Reynolds risk score becomes so critical in the decision making. But I would expand it beyond, do I care about just the next 10 years for the patient, or do I care about their longer term risk as well? And if you care about longer term risk, then it does move you down the age curve to say, do I want to start treating earlier? And we do have some data from the genetics, PCSK9 variants, where people through their life are kept at LDLs because they're genetically blessed and have upregulation in LDL receptors, at LDLs of 50, and those patients, or 90, where their lifetime relative risk reduction is much larger than the trials, where it's on the order of 70, 90%, because they've never been able to even form those atherosclerotic plaques. It's not just about stabilizing, it's about preventing.
Right, but I think I would say that we don't have a lot of data on that, young person who's 20, maybe with a lifetime risk, 5 to 10%. The benefit of starting at 20 versus 30 versus.
All we have is the genetic data. We do have, though, in the primary prevention studies, very nicely, I showed this slide super quick, about the placebo. So let me, the actual trials that show for primary prevention that follows the curve. First, the data that pulls all the trials together shows no heterogeneity whatsoever in benefit between primary and secondary prevention of risk reduction. Here on the big trials, Western Scottish, TEX-CAPS, APCAPS, ASCOT, and Jupiter, you can see where, why does it not perfectly follow this down? There's a little jump up here because Jupiter did have this little one up on the entry criteria, CRP about 2, so both placebo and treated group that were just up in their risk. It's not quite there, but you can see it follows this curve down at a very low event rate the lower the LDL goes. And so we see this continuum. But you're completely correct, your events per 100 years, we're not up at the secondary prevention curve where it's, here the scale has changed, we're 5 or 10%. So then it comes to number needed to treat.
That's why I think that, in Jupiter, that's why you got to keep that absolute.
And so MNT in Jupiter is 25 over 5 years, is very respectable. But Jupiter has the additional component, they have an age criteria. So I think, the closest is TEX-CAPS, APCAPS, where those were 40 to 60-year-olds. Incredibly healthy. They had a 38% reduction in the first major cardiovascular event. But the number of deaths in that whole trial was 18. They were followed 5 years, So that issue of if your goal is just make people live longer over the next 5 years, you can make a strong argument against primary prevention. If your goal is preventing fatal and non-fatal events, then primary prevention comes in. If it's saving lives, but you expand your population a little larger as a time frame to say I'm going to follow them out 10 years, then you're there. Or if it's aggressive LDL reduction, like I showed you in Jupiter, even in a 2.5-year time frame, you can cut those deaths in half.
Let me move on to others. Ronnie, you got your hand up.
Yeah, first of all, excellent talk. Several questions. In the practical world, there are folks that can't or shouldn't be on some of these medications. Of the 4 medications that you mentioned, is there which ones have the highest cardiovascular protective risk? Statins, could you list them? Number 2, somebody who has a high HDL, and maybe you mentioned this in your talk, but I didn't hear it. Is there HDL reaches a certain level, is that protective enough not to be on these medications? And third, is there age? I mean, would you put a 80, 90-year-old on it?
Okay, all great questions, all that come up frequently. So magnitude of benefit, it does depend on your population. The greatest magnitude for pure secondary prevention, normal LV function, we're putting heart failure aside, comes from your statin. If they're not post-MI, arguably your ACE inhibitor and beta blocker compete for the number 2 and 3 slot, and your aspirin comes into your 4th position. That said, most patients don't have contraindications that would make you have to make that decision whatsoever, and if they do exist, super high risk of bleeding because of prior intracranial hemorrhage, there it's specific to the aspirin, it doesn't impact the others. You could reverse it if it were LV dysfunction patient, in heart failure, beta blockers trump statins so many fold that the statins are hard to show there's benefit in a heart failure population. So for that magnitude of benefit component, are rarely having to pick and choose, especially because economics are out of the equation. The challenge of taking, you know, in your hand one pill versus 4 individual pills that all can be once daily, well tolerated, allow you to where you don't need to pick and choose anymore, and the full bundle or full combination or completely champed up as set and use away can apply. If an absolute contraindication exists, are there ways around it? You know, if somebody's hypertensive, there are other antihypertensives despite a contraindication to beta blocker. If somebody has a contraindication to statin, they develop rhabdomyolysis, not tolerate a statin, then we're left with our other LDL lowering drugs that are less well tolerated, less efficacious, but that, you know, we just make the best that we can. Now, why didn't I mention HDL, triglycerides, all of these great, you know, millions of talks and publications